Good evening, sir.
Happy
Sir,
birthday.
thank you.
Happy birthday to you.
कोणाचा आहे?
कोणाचा म्हणजे आपला
Sachin, you can start. Sachin.
एमॉक्स चॉकलेट हिरो.
Thank you, madam.
Sir, wish you a very happy birthday.
Thank you.
हॅपी बर्थडे सर.
काल होता, आज नाही, काल होता.
पण बर्थडे चालू
ओके देन बिलेटेड.
आपण आजच समजू.
हा आम्ही एका दिवसाने उशीर पोस्ट मीटर झालं काही नाही होत.
कोजागिरी पौर्णिमा. कोजागिरी.
Ma'am, we are recording and it's live on
So, sir, we
YouTube.
can go live and we can start the PPT
Sachin,
right now.
Sachin, please start.
Yeah, so good evening, and first of all, wish you very belated happy birthday, Mr. Amay, Dr. Amay sir. This is Sachin Amte from the Walter Bushnell, working as a RSM from Pune, based at Pune. So I welcome on behalf of the Walter Bushnell and Martin Harris team to with this live webinar. Feroji, first slide, please. So I'm introducing Dr. Jyoti Sool ma'am. She has completed.
Mr. Mas, please share the slides.
Yeah, please.
Yes, full screen.
Make it full screen. So once again, all welcome all the delegates. So I'm welcoming Dr. Jyoti Sool ma'am. She has completed MBBS MH obstetric gynae, and she is presently attached with the director and as a director and consultant at Phulabai Bansude multi-specialty hospitals, Sool hospitals as well as Latur, and special area of work interest is health awareness camps, high-risk pregnancy, got many awards for the social awareness. Welcome, Dr. Jyoti Sool ma'am. So I'm handing to Dr. Jyoti Sool ma'am.
Thank you so much. Now we are going to inaugurate formally in presence of our esteemed chief guest, Pardesi sir, Amay sir, Meg madam. So inauguration slide, please.
Next.
Next wala.
Play the video.
I welcome you all. Now I am going to introduce our PAC chairperson, Dr. Monica ma'am, who has made the PAC committee PAC. She is given so much good impact on us. She is consultant, obstetrician, gynecologist, Mangalaya Nursing Home and Atharva Fertility Center. She is PAC committee chairperson, as I told you, website coordinator for AMOX 18 and 20, youth coordinator AMOX 2020 and 22, executive member PAC 2019 to 22, executive member 2019 2020.
Dr. Jyoti, that should be enough.
Treasurer.
That's okay, don't worry. You can go ahead.
Everyone knows you, ma'am. Thank you, ma'am.
Thank you for the kind words of introduction. I just wanted to update that this PCOS update was actually scheduled in September, as September was a PCOS awareness month. But however, we had the state conference, and taking it to the priority, we have shifted this webinar to October. I would like to thank Dr. Pardesi sir for giving us the opportunity to conduct this under the AMOX banner, and Dr. Abhay Puradre sir and Dr. Mandakini Beg madam to join us and give the blessings for this webinar. I would like to formally introduce each one of them because each one of them is very special to our committee. Dr. Rajendra Singh Pardesi sir is the president of AMOX currently. He is at the help of the institute, but yet so humble that he is approachable to each and everyone in AMOX, and we feel connected with you, sir. He is also has been a national and international faculty at various conferences.
It's
and
okay.
He is also,
it's okay. Okay, Monica, we can skip
sir.
that.
So can you please give the blessings to this webinar, sir? Thank you so much.
Respected DIAS dignitaries, mainly our grandmother, Dr. Meg Madam, Dr. Ame Purandare, Vice President, and our ever active chairperson, Dr. Monica Ubadand, and her active coordinator, Jyoti Sul. First, I wish to congratulate Dr. Monica, Dr. Jyoti Sul for organizing this wonderful webinar with Aurangabad, Chandrapur, Latur, Nashik, Parbhani, Pune, Solapur, and Thane societies. As you know all, and you are enlightening in this webinar on PCOS. PCOS affects the women's health in all aspects, not only infertility, but all aspects. And the speakers, Dr. Manjiri Valsankar, Dr. Chaitanya Ganpule, Dr. Varsha Baste, and the panelists, they will enlighten you in this webinar. Dr. Monica is ever active chairperson in AMOX, and she is very regular and steady in doing her activities in AMOX. So I again wish every success to Dr. Meg Madam, Dr. Baste Madam, and the Chaitanya Ganpule for their future endeavors in FOXI. I wish every success to this webinar. Thank you. Thank you so much for inviting me.
Thank you, sir, for the kind words and blessings to this webinar. We now move forward to introduce the guest of honor, Dr. Abhay Purandare, sir. Can we have the next slide, please? He has been my undergraduate teacher at Subaya, and he has been the guiding force since then. He is a consultant obstetrician and gynecologist at Purandare Hospital and KJ Subaya Medical College. He is also attached to HN Reliance Bhatia and Masira Hospitals in Mumbai. He is the second vice president of 2020-24 currently, and he has been the joint secretary of FOXI 2019. He's also been the chairperson of the Food, Drug, Medical, Surgical Equipment Committee and the assistant administrator of FOXI in the project.
Monica,
We welcome you, sir. Yes, sir.
Thank you.
Yes, sir. Thank you.
First of all, I'd like to thank Monica for inviting me to be part of this webinar in the capacity as guest of honor. Monica and Shashikant are both my students from Somaya days, and I still remember Monica very sincerely attending all my lectures then. But I think that Monica is one of the most dynamic chairpersons of AMOX, and Dr. Pardesi will agree. And I think it's very apt that she has taken up this public awareness committee, because I think we need somebody who is so dynamic and who wants to reach the masses. So very well done, Monica. I also like to congratulate and appreciate and acknowledge all the faculty who have joined together this evening from the various societies across Maharashtra. I think truly AMOX is showing how united we are and how committed we are to the organization. Last but not the least, the topic is PCOS, and I think Monica has identified all the aspects of PCOS that we will be learning about today. I strongly believe that PCOS is no longer just an infertility problem. It is a lifestyle problem, because it is affecting the women right from adolescence up to the perimenopause and even beyond. So I think all the aspects are covered, and we must take back important messages to our patients and create the health awareness that Dr. Pardesi is so much passionate about in his tenure as AMOX president. So once again, congratulations, Monica, and thank you for having me here. And I really appreciate the efforts that you are putting in and all the faculty who have put in today. Also, Dr. Mandakini Meg, who as ICOG chairperson had taken this topic of PCOS and created special modules for the same to have a concrete, individualized approach to PCOS. And I'm happy that Madam has joined us today as guest of honor. And like Dr. Pardesi said, that our best wishes are always with Madam. She, in fact, her best wishes are always with us. So, Madam, we are always there for whatever you want to carry out. We are your soldiers, and we wish you the best. Thank you. Also, best wishes to the others, Dr. Varsha Baste and Dr. Chaitanya, who are sincerely carrying the flag of AMOX at FOXI. Thank you.
Thank you so much for your kind blessings, sir, and thank you for guiding me all throughout. Thank you for your blessings for this webinar too. We will now move forward with Dr. Mandakini make Madam's introduction. Actually, Madam needs no introduction throughout India. She has been the ICOG chair in the year 2021, and her work during her tenure was much appreciated by all. She is also the International Vice President of the MWIA Central Asia. She is the Vice President of the AMWI Central Council and has been the National Vice President of FOXI in 2012 and 13. She is also attached to the government sector and has contributed a lot to the contraception and abortion clinics,
Yeah.
as well as the laparoscopic sterilization clinics in the rural health sector. We welcome you, ma'am, as a guest of honor and are seeking blessings for the same.
So good evening, everyone. Dignitaries on the dais. My very, very favorite Dr. Pardesi, President of FOXI. We are there, and he's calling me mother too. He has, improved my, done my promotion to grandmother. So I am very happy, and I give blessings to everybody. And Dr. Pardesi, we have relations since last 40 years. So Dr. Pardesi is just like my younger brother. So thank you very much. And Dr. Pardesi, first of all, I congratulate you, because under you so many chairpersons are being just त्याला मराठीत म्हणतात फुलून राहिलेले ना, they are just being bloomed, and I think that is the quality of the leader. With other vice presidents, my favorite Dr. Amme and Dr. Kiran Kirtakoti, we were together in the MTP committees. With Amme, I think you done with his father, grandfather, I can say, and now Amme, तीन पिढीचा आमचा संबंध आहे. And we are thickly one, relationship, and I think that carries the. So first of all, congratulations to the president himself. Taking everybody along is the leadership, and that is the quality I see in Dr. Pardesi in so many years. Very polite, very humble, and very all the time he is available. Whenever I want any kind of help, or even I have helped everybody, but if I in the middle of the night, if I require anything. So Pardesi is there, Ame is there, and of course Monica is my soldier. So Monica, so second congratulations goes to you as a PSC. I have seen many PSC from Odisha. That time only the committee and the chairperson photo used to come, and later on there was no activity. If you may remember that PSC chairpersons from Odisha, and I thought that a PSC Faltu committee, they don't do. And the moment people are taken over as a PSC has become a very glamorous, I said, it's full of activities. So it is the person who puts life into those committees and come out with such brilliant programs, bringing all the brilliant people together. And I can congratulate with you co-host this Dr. Jyoti. Congratulations to the Latur Society, Aurangabad Society, Chandrapur, Pune, all the societies coming together. And that is also second quality I like about Pardesi and his team, and myself also, because I am in his team. That taking all the efforts, and I can see so many committees, so why to duplicate the efforts? Everybody coming together and giving the knowledge. I think I have learned in the ICOG, which you have mentioned very correctly, that we all India centralized teaching. And I remember Dr. Alka Kriplani, Dr. our Narendra Malhotra and Jaideep saying that अरे हम लोग तो इतने दिन से ICOG chair थे पर हमारे दिमाग में कैसे नहीं है. So adversity is the best, best to teach us, and they teach us so new direction. So I think you people are doing a great job, and also you got a wonderful panel. As PCOS, Amaya said very correctly. Yesterday I was in a CME. They were saying, "Arey, so before some years we were not knowing what is PCOS. Now it is all PCOS because the diagnostic tools have increased. And PCOS not only in the infertility, but in the PCOS in the adolescent, PCOS in the even for menopause. Also, so many PCOS has become a lifestyle disease. And today you led up a wonderful program. And all Varsha Baste, all the people, Kiran, this Ganpule, and all the faculties, I think they're going to do the great justice to the subject. And I think we will go one step ahead in our gaining the knowledge. So all the best, Monica, team, and all the faculties for your inputs. And thank you very much for inviting me and wishing me all the best. I have always won the election because Maharashtra was with me. And Maharashtra, on the strong shoulders of Maharashtra, I will also ride in this new post. And I promise you, I will give you the best as a President Foxy if I get elected. Thank you very much. Thank you.
Thank you so much, ma'am, for your kind words, and we wish you all the best for all the endeavors in the future. We thank Dr. Pardeshi sir and Amay sir for joining in as the as our special guest for the evening today. And the topics for today have been crafted thinking into point of view of prevention as well as early diagnosis in all the stages of life. We will be having a panel discussion on the adolescence PCOS. We will be having the metabolic syndrome and its prevention and infertility and the diagnosis part of it, so that we are at least able to educate our patients about how to prevent the complications in future life. I now hand over to Dr. Jyoti Sool for the further conduction of the meeting.
1 minute, Monica. I want to acknowledge
ma'am.
the presence of Anjali, president of, because I just saw her. Then Jyoti, then Dr. Chaitanya Ganpure, Manjiri, a great, academician, Dr. Kishori, Dr. Nagina, Dr. Priya, our Priya, then and Vaishali Surse. So all these people, and I think I have not left anybody. So thank you very much for allowing me. Thank you.
Thank you so
Dr.
much.
Jyoti, take over.
Yes, ma'am. Thank you. Now we are moving towards our first topic, that is stepwise approach to PCOS infertility patient. I welcome our chairpersons for this topic, Dr. Anjali Jama madam from Solapur and Dr. Vaishali Datar madam from Latur. Dr. Anjali madam, she is a president Solapur OBGYN Society, consultant at Jama Hospital and Laparoscopy Surgery Center since 2000. It is the first laser gynecology center in Solapur and nearby districts. Her area of interest is cosmetic gynecology. She was secretary 2015-16 in Solapur OBGYN Society, treasurer in 2013 and 14, organizing secretary for 2 zonal conferences. She is, yes ma'am?
It's okay.
Welcome Anjali ma'am. The next chairperson is Dr. Vaishali Datar madam. She is president of Latur OBGYN Society, practicing gynecology for since 20 years. She is director of Sarthak Hospital. She was past treasurer and secretary of Logs 2005 and 6. She conducted numerous tubectomy camps at PSC, conducted various educational workshops, and she has been invited as a faculty at state regional conferences. Her special interest in infertility and high risk pregnancy, and right now she is doing a good work in colposcopy. Welcome Vaishali Datta madam. And I request Zama ma'am to introduce today's speaker.
Yeah.
I request Anjali ma'am.
Good evening, one and all. Thank you, Pardeshi sir, Meg madam, Amay sir. I would like to congratulate Monica for organizing most needed webinar on PCS. And thank you for giving me this opportunity. Our opening batsman for today is Dr. Manjiri Valsankar. She has done diploma in endoscopy in Germany and fellowship in minimal invasive gynecology in BMC and fellowship in infertility. She is a director and consultant IVF specialist in a Bide Hospital Test Tube Baby Center, Pune. She is a very good orator, and she has delivered many speeches in national and international conferences, and she is from Solapur also. And over to you, Manjari.
Thank you so much, madam, for that kind introduction. And at the outset, I would like to thank Dr. Monica, Dr. Jyoti, and Team AMOGS for having me here. I think Dr. Maz needs to allow me to screen share. I cannot share the screen because...
Now you can share, ma'am.
Yes, now I will be able to share. Thank you so much. So my topic for today is approach to a PCOS infertility patient. I understand that this is a PAC committee talk, but I'll try to be more precise and value oriented as far as PCOS is concerned. So PCOS is nothing but it's just like a Rubik's cube in which there are so many multifactorial complex pathologies. You go on and on to get all the colors in the same line, and not all the times it is possible. So it is a large magnitude of the problem. It's a complex heterogeneous disorder, right, ranging from adolescent to menopause, characterized by hyperandrogenism, ovulatory dysfunction, polycystic ovaries, and commonly associated with other abnormalities like insulin resistance, hyperinsulinemia, and the metabolic syndrome. In fact, 40% of our infertility patients suffer from PCOS. We all know how to diagnose the PCOS. It is from the Rotterdam consensus of the ASRM, that is the Rotterdam's criteria, which either 2 out of the 3 have to be positive for us to define the patient as PCO. So it includes oligo or anovulation, hyperandrogenism, which can be the clinical or biochemical, and polycystic ovarian morphology on ultrasound. So if we see the commonest symptoms of PCO, we have around 90% of the women who come with oligomenorrhea. So many of them bleed just 4 or 5 times a year. Some do not bleed without withdrawal at all, and they have to be given every so many times. Around 40% of the women have complete amenorrhea. 30% of them have hyperandrogenic features like acne, acanthosis nigricans. 95% are anovulatory cycles. Recurrent pregnancy losses, the PCOS is one of the major burden, which amounts to 42 to 73% of the recurrent pregnancy losses due to PCOS, and also results in hirsutism and androgen excess disorder. Now, basically, insulin resistance or hyperinsulinemia is the main culprit, which changes the hypothalamo-pituitary ovarian axis, thereby resulting in a reversal of the LH-FSH ratio affecting the reproductive system. The ovarian androgen synthesis is elevated, and the hepatic SHBG production is decreased, as a result of which it results in hyperinsulinemia, hyperandrogenemia, and because of the reversal of the HPO axis hormones, it causes anovulation or oligoovulation, thereby resulting in a diminished oocyte quality. So all in all, if we have to see the reproductive outcomes of PCOS, they are right from menarche to menopause, the commonest being infertility, miscarriages, and pregnancy complications. So what is so different in PCOS that we thought of having an entire webinar on PCOS? Let's go to the basics to understand this. Insulin resistance is the main culprit in physiology of PCOS, which results in hyperinsulinemia, thereby resulting in theca cell proliferation and resulting in the polycystic ovarian morphology. But in fact, nobody yet knows the exact cause for PCOS, and that is the whole issue. So there are certain problems which are very specific to PCO patients, which have to be understood before we take care of their infertility parameters. Whenever we are talking about fertility pertaining to PCOS, there's always an increased sensitivity to gonadotropin, resulting in explosive follicular recruitment. There is complete reversal of the LH, AMH, AFC, and thereby resulting into the fertility parameters. Preantral follicles in PCO patients are always twice as compared to the non-PCO subjects, thereby resulting in a very diminished oocyte quality, and that is where is the main concern about infertility. All in all, there's also a large arrested cohort which responds to the exogenous FSH really fast. So it's just like a ticking bomb which can explode at any given point of time, and hence we have to be very careful. Now, there are a set of pre-fertility management strategies or protocol to improvise the fertility parameters in a PCO patient, which we shall discuss in the form of lifestyle modifications like the diet, exercise. We can also use insulin sensitizers. It is very important here, I need to make a point that in spite of whatever body mass index of our infertility patient of PCO, the lean as well as the obese one still has insulin resistance. There's a lot of misnomer and a misconception that the lean PCO might not have a hyperinsulinemia. It's the other way around. In fact, the lean PCOs are the ones which have too much of hyperinsulinemia as compared to the obese PCOs, and they are the difficult nuts to crack. Apart from insulin sensitizers, the hyperandrogenemia and the peripheral parameters need also to be addressed. Now, whenever we are using insulin sensitizers, so now that we have a PCO patient coming to our fertility OPD, we have seen her, examined her for various features, and we have diagnosed her as a PCO patient. And my patient here is an obese patient, and I have to choose between the insulin sensitizers which are available. So to understand whether metformin or myoinositol should be applicable, let us see the insulin signaling transduction pathway. So the insulin binds to the receptor at the membrane, and metformin, if you supplement, will stimulate this PI3 kinase, which is nothing but a security guard. And whenever there is excess of glucose, it stimulates this GLUT4 receptors, which causes utilization of your excess glucose. Inositols, on the other hand, not only act as stimulator of this enzyme, but also act as precursor in deficiency states, especially like PCOS. So given a choice between whether to use metformin or myoinositol, now I think there is enough data, a lot of meta-analysis have been available which have stated that inositols is the way through. It is safe to use inositols even in the first trimester, and they are mild, just dietary supplements without any side effects. So we know that inositols regulate the blood glucose. So in our obese as well as thin patients, if a patient is having hyperinsulinemia, she is the right candidate who can be given inositols. Metformin also can be given, but it has a lot of gastritis, acidosis, and very rarely hepatorenal parameters can be changed. So if we have to understand our inositols, there are two types of inositols: myoinositol, which acts on central tissues like the brain, ovary, and the heart, which is responsible for glucose cell uptake, while the D-chiro-inositol, which is the peripheral conversion, which is seen in the liver, muscle, and the fat, which is responsible for converting that excess glucose to glycogen. So the rationale is, if you have a patient who is ovulating fine, she does not require inositol, she requires only D-chiro to take care of her peripheral symptoms. If you have a thin PCO patient who is not ovulating at all, but does not have hyperandrogenemia and insulinemia, you can give her only myoinositol. So there's a huge range of combinations which are available in inositols to be used. And I think that will be addressed by Dr. Ganpule sir in the subsequent talk. So how to approach a PCOS infertility patient? For approaching anything, we should know what our end result is, what is expected. So the goal of ovulation induction in PCOS has to be always, primary goal of ovulation induction is to stimulate monofollicular development, resulting in a successful singleton pregnancy. So we have an obese patient, check her BMI, do her OGTT. OGTT is the way out. There is no role for fasting, PP, glucose insulin ratio, or so on and so forth. All the standards across the globe have communicated that OGTT is the one to diagnose hyperinsulinemia in PCO subjects. Suppose you have a thin patient, obviously you do her BMI and her OGTT as well to check whether your patient is ovulating or she is not ovulating on a baseline folliculometry. If she's ovulating, we go ahead and our plan of management should be controlled ovarian stimulation with timed intercourse if there is absolutely no problem with the semen. If she's unovulatory, we require to post her for a controlled ovarian stimulation with an IUI cycle. Adjuvants, as we discussed, can be used are metformin, inositols, vitamin D, berberine. You must stop at 3 IUI cycles only, because it is a known fact that in PCO subjects, your fertility rate reduces drastically if you do anything more than 4 or 5 IUI cycles. Some absolute no-nos which I have highlighted here. There is no role for PCO drilling. Please don't do it. There is no role for diagnostic laparoscopy in PCOS just because your patient is not getting pregnant. You need to figure out certain other parameters which you might have missed. There is no role for downregulating PCO patient with oral contraceptives anymore. So there is absolutely no role of OCs in PCO just to regularize the cycle. The larger cat is there, which is the fertility problem, which needs to be directly and precisely addressed. Start with controlled ovarian stimulation straight away if a patient is not ovulating, and we have to pledge for being a OHSS free clinic. Investigations which are now mandatory as per the recent standards are ideally in a fertility patient, only AMH and antral follicular count, a good baseline scan on day 2 for dosing your patient. There is no role again for FSH LH routine analysis. And it is important, obviously, to rule out hypothyroidism and hyperprolactinemia, which is coexisting in many of our PCO subjects. They say that waist-hip ratio is ideal, but in a busy OPD, it's impossible to do these things, and hence BMI should be considered as a good enough standard. According to the Endocrine Society, every fertility treatment has to start with lifestyle modification, which includes exercise, getting your patient to a insulinemic state, and basically getting her ready for the further fertility management. Now that we want to start stimulation in a patient, how to assess the ovarian reserve and how to dose her. So the antral follicular count, AMH, previous response, age, and BMI will help us decide the ovarian reserve assessment strategy. Once we have understood the ovarian reserve, this is also called as AFC scan, which has to be done, which is a baseline scan along with ovarian volume, stromal flow, and the receptivity of the patient. You can absolutely assess a patient without doing a single biochemical investigations if you invest your time in learning Dopplers in infertility sonography. So if your AFC scan is done, AFC scan is nothing but a day 2, day 3 scan, which gives us a quantitative and qualitative assessment of the recruitable cohort, and it correlates with the ovarian age of the patient and the ovarian reserve. So if we see the AFC scan, if your AFC scan is less than 5, she's a potential poor responder. But today we are talking about our PCO potential hyper responders. So any patient with an AFC more than 12, be alarmed and start with the lowest dose of oral ovulagens or gonadotropins. Now, this particular pattern is very important. PCOS has various manifestations, commonest being the central cystic pattern, but the most severe being your peripheral necklace sign, which is the end stage of your PCOS biochemically, hormonally, and sonographically, and these are the difficult cases to handle. Basically, if we see the entire hierarchy, insulin resistance results in hyperinsulinemia, hyperandrogenemia, elevation of your interleukins, and because of this, if we see there's a theca cell proliferation resulting into stromal hypervascularity and stromal abundance, thereby pushing the peripheral follicles outside. So a classic PCO looks like this, with a peripheral sign with more than 12 antral follicles, with a high ovarian volume, anything exceeding 10 centimeter cube, and a highly echogenic bright stroma, which means your patient is up for hyperstimulation and you have to give the lowest dose possible. So when we are dosing our patients, this is how a hyper-responder ovary would look like if you do a proper Doppler scan on the second day, which is a baseline scan. So ovulation induction in these patients, first line has to be oral ovulagens, the second line has to be gonadotropin, and the third and the resistant cases go in for ART management. Now we have diagnosed our patients as having PCOS. We have seen all our hyperinsulinemia, hyperandrogenism. We have treated all this with lifestyle modification. We have seen our antral follicular count. And now I want to start for the definitive management in this patient of mine. So clomiphene or letrozole which is better. It is beyond doubt that clomiphene is the first line, but however, the recent studies have refuted it, and letrozole is the ultimate line of management if you're using oral ovulation in PCO patients, because CC always comes with CC resistance, in which the patient fails to ovulate, and CC failure, in which she does not get pregnant in spite of ovulation. So if we have to do a head-to-head comparison between clomiphene and letrozole, clomiphene has a very longer half-life. Letrozole is just 45 hours. Clomiphene comes with side effects of thin endometrium, which are not seen with letrozole, and letrozole has absolutely less incidence of miscarriages, OHSs, and multiple pregnancy, and hence there are various trials. I have picked up the Legro trial, which is a really huge trial in which 750 PCO patients were recruited in a randomized controlled trial. Half of them were taking clomiphene and the other half were recruited in letrozole. Up to 7.5 milligram of letrozole was given to see whether the patient ovulates, then followed by IUI at 36 hours. This was the head-to-head comparison, and each and every parameter showed beyond doubt that letrozole is much better as compared to clomiphene in all PCO subjects. And as far as the live birth rate and the clinical pregnancy rate is concerned, it is absolutely a convincing thing. So the Ledgrow trial concluded that letrozole was associated with higher live birth rates and ovulation rates and was much superior to clomiphene as a treatment for anovulatory infertility in PCO subjects. Now, anything different in folliculometry of our PCO subjects? Whenever we are doing folliculometry, it is important to evaluate the expected ovarian response and the actual ovarian response in folliculometry in each and every PCO patient with respect to the number and size of the recruited follicles. Early and timely identification of ovarian hyperstimulation is absolutely important. It is also important to identify a very poor response, because if you have to cancel the cycle, it should not amount to a financial burden to the patient. To decide the optimum time and type of the trigger, and of course to ascertain the luteal phase as well. So now this patient of mine, I have given her letrozole for 3 cycles. She did not ovulate, and then I decided that I have to step up the protocol and make her ovulate with the help of our magic drugs, gonadotropins. So how to use gonadotropins? There are various ways and methods of using gonadotropins. You can either do a step up or a step down protocol, in which you start with a higher dose and then step down, which is not advisable as such, or start with a lower dose and then step up. You can give your gonadotropins in a sequential protocol, in which, let me explain, day 2 to day 7, letrozole, followed by day 8 onwards, daily dose of gonadotropins till your lead follicle reaches around 18 to 19 millimeter, and then trigger her. You can also use a conjunctional, which is day 2 to day 7 letrozole, followed by alternate day conjunctionally with your oral ovulogins till your patient ovulates. However, there are studies beyond doubt that the sequential protocol is much better in obese as well as thin PCO patients as compared to your conjunctional gonadotropin protocols. Anything more than 4 follicles in IUI, it is important either to convert the patient, and if there is no follicle beyond day 15 to 18, please cancel the cycle. One has to expect the unexpected in PCO. Anytime anything can happen, and hence we should have a very high index of suspicion whenever we are using gonadotropins. So this is the conjunctional regimen which I explained, and this is the sequential regimen, so which includes the daily dosage followed by trigger. So it has been noted that the ovulation and clinical pregnancy rates are much better with gonadotropins and letrozole regimen as compared to oral ovulogins alone. And it is now time that we do not get afraid of stimulating our patients with gonadotropin because of advent of agonist triggers. So all in all, more than 4 follicles, counsel her, convert to IVF. If she's not willing, counsel her, cancel the cycle, advise abstinence, and put her on cabergoline. Now, when to do IUI? So this patient of ours, we have seen whether she's obese or lean. We have regularized her as far as her androgen and insulin parameters are concerned. I stimulated her for 3 cycles with COH for timed intercourse. However, she did not conceive, and time to pregnancy, infertility in PCOS is very important, because if I don't do anything, then the patient will obviously land up with my friend, and rather I do IUI and increase her chances of pregnancy from 3% in natural intercourse to around 15 to 20% in IUI. So IUI should be done in anovulatory subfertile PCO women with a male factors of fertility. Don't give natural trials, step up for IUI straight away. It is recommended to 3 unsuccessful conception attempts despite ovulation induction, and especially in unexplained infertility or super added factors like mild or moderate endometriosis. So all in all, it is extremely important how you evaluate a PCO patient. That will decide how fast the results will come, and it has to be, it has to be an actual protocol in our mind that, okay, this is how we will evaluate the patient. This is what is the troubleshooting, especially in stimulation patients and getting them pregnant. Safety comes first, and we proudly present ourselves as a OHSS free clinic since last 8 years, and almost many clinics across India are having this tag. So all in all, let me summarize this. If it is an obese patient with a BMI OGTT deranged, lifestyle modification, correct it first. If she's an ovulatory patient who's less than 35 years with a good ovarian reserve, good AMH and antral follicular count normal, try for 3 cycles with timed intercourse if the semen is normal. If she fails, you can step up to 3 IUI cycles. If she's ovulating, fine. If everything fails, counsel her and get her into an IVF cycle. In thin patients as well, correct the hyperinsulinemia if at all it is there. BMI is not a problem in our thin cycles. They are generally very unovulatory patient. In spite of giving a very high dose of gonadotropins, they don't budge. So only 3 cycles of IUI with gonadotropin, especially if you're not getting the desired results. If there is absolutely no folliculogenesis, in spite of giving a decent dose for 3 cycles, sit across the table, counsel the patient that we are looking at a larger picture. We need to give you results. There's absolutely no follicle that is created or there is no ovulation. You need to step up for ART. So in PCOS, if we see, there is no one size fits all formula for success. My favorite cricketer is Sachin Tendulkar, and he was asked that what is the success? So he said that I keep it simple, watch the ball and play it on merit. So every patient of PCO is completely different. We need to individualize each and every patient. There is no one size fits all policy, and the stimulation of the patient, or even right from assessing that patient and step-by-step approach in a PCO patient, will completely be individualized for each and every PCO patient. So actually the right protocol is individualized controlled ovarian stimulation, which has to depend and which has to be tailor-made for each and every patient, depending on the age, BMI, AFC, AMH, previous hyper or poor response. History taking is the most important thing in fertility, which we are missing. It is very important in the technology versus touch. We have lost that touch thing. We are so technologically oriented that touch and history taking has to be still an integral part of all fertility practices, and then comes the technology. So thank you so much for a patient listening, and I hope I have finished in time. Thank you, Dr. Monica, and thank you, Dr. Jyoti.
Good evening, everyone. Hello, am I audible?
Yes, you are.
Yes. Good evening, everyone. First of all, thank you, Dr. Monica and Dr. Jyoti, for giving me the opportunity. In our day-to-day OPD, nowadays, there are 70 to 80% patients diagnosed as PCOD. Ma'am, you have explained very nicely about diagnostic part, PCOS criteria by Rotterdam, symptoms part, how to correct PCOS by diet, exercise, metformin, and inositol, insulin sensitizers, goal of ovulation induction in obese and in thin patients. You have explained very nicely, ma'am. Investigation part was covered very well. Result assessment by a baseline scan, comparison of CC and letrozole. All points about PCOS have covered very well and stepwise. It was really a very informative and fruitful session, ma'am. Thank you.
Thank you, Dr. Vaishali, madam, and thank you, Dr. Monica and Dr. Jyoti, for this opportunity.
Now over to Dr. Jyoti and Monica. Dr. Monica.
Thank you, ma'am.
I would like to thank which and Gracie. It was an exhaustive talk. Thank you so much.
Thank you, Dr. Manjari. If you have any questions, then you can put in inbox. I request everyone, and please, Dr. Manjari, be connected for 5 to 10 minutes. If there is any question and answer in inbox, you can answer it. Okay. Now moving towards the next lecture, I welcome our chairpersons, Dr. Anjali Vare madam and Dr. Prasad Magar sir. Dr. Anjali ma'am. She is president Aurangabad Pcos Society. She is consultant at Vare Hospital Aurangabad, practicing since last 27 years in high-risk obstetric and sonography. She conducted adolescent health camps in school and colleges and worked in obstetric HDU. Next chairperson is Dr. Prasad Magar sir. His special interest is in infertility, high-risk pregnancy, medical disorder in pregnancy, and he is president Parbani since 2020. I request Dr. Anjali ma'am to introduce our next speaker, Dr. Chaitanya sir. Magar sir, Anjali ma'am.
Here. Okay. Good evening. First of all, I will like to thank Dr. Monica madam and Dr. Jyoti for giving me this opportunity to chair this session. Our next speaker is Dr. Chaitanya Ganpule. He has done his MD OBGY and he has done diploma in gynec endoscopy from France and certified in IVF from London. He is a treasurer of Pune Obstetric and Gynec Society. He is the chairperson of Midlife Committee AMOX and national coordinator of Foxy Endocrinology Committee. He is a director of Pearl Women's Hospital.
That should be good enough, madam.
Yes, yes. Please, sir. I welcome you.
Sorry, that I think that should be good. We'll start because it's a very exhaustive topic for me and it will take a little while. So rather than spending time in introduction, let's start with the talk. Can I share my screen, please?
Screen share.
Can you see?
Yes, sir.
Okay. At the outset, I would like to thank Dr. Monica and Dr. Jyoti for giving me this opportunity to be here today with you all, along with Pardeshi sir, who has been at the helm of the affairs and such a humble person to be there in that chair. And I'm going to talk today about PCOS, metabolic syndrome, and its after effects. Now, we have just heard Manjiri speaking about the infertility aspect of PCOS and the treatment for infertility related to PCOS. That's exactly what comes to our mind when it comes to PCOS. Whenever we say or hear a word PCOS, the thing which comes in our mind is infertility. So we don't go beyond infertility when it comes to PCOS, and that's exactly what I'm going to talk about or speak about today in next, say, 25 to 30 minutes. So I'm going to go through what is about something about PCOS and its presentation, and then definition of the metabolic syndrome, what constitutes metabolic syndrome, androgen excess and its implications, insulin resistance and hyperinsulinemia, cardiometabolic consequences of metabolic syndrome, how to diagnose it, risk assessment for metabolic syndrome, how to treat it would be my last part of the talk, and we will conclude the session thereof. So PCOS is an endocrine disorder that affects about 20% women of reproductive age group. Its prevalence is increasing steadily over years, and it has a wide spectrum of presentation. As we have just discussed, that the most commonly it is found either in the adolescent age group when she presents to us with irregularity in the periods, or in the reproductive age group when she presents to us with infertility. But there are other presentations as well with which a PCOS woman can present to us, like alopecia, obesity, acanthosis nigricans, depression, mood disorders, acne, and hirsutism. So we all know that there are 4 different phenotypes of PCOS that are now identified: type A, B, C, and D. Whatever the type of phenotype it would be, hyperandrogenemia remains the hallmark for polycystic ovarian syndrome. Now, there are various definitions which has been put forth for PCOS. One by NICHD in 1990, then the Rotterdam, which came in 2003, and then the Androgen Excess PCOS Society definition, which came in 2009. But the most commonly used of all the definitions is by the Rotterdam criteria, which says 2 of the 3 should be present: clinical hyperandrogenism or biochemical hyperandrogenism, oligomenorrhea, less than 6 to 9 menses per year, or oligoovulation, and presence of polycystic appearing ovaries on ultrasound, wherein the antral follicle count is more than 12 in one ovary and the ovarian reserve or ovarian volume is more than 10 centimeter cube. What do we know about PCOS? Well, we know that and hyperandrogenemia is the biochemical hallmark of PCOS, and insulin resistance is the essential pathophysiologic mechanism in the development of all metabolic complications of PCOS, which you are going to see in next 15-20 minutes. So what is the definition of metabolic syndrome? It is a cluster of conditions that occur together, increasing the risk of heart disease, type 2 diabetes, and stroke. That means all women who are presenting to us with PCOS have a potential risk of developing an heart disease, type 2 diabetes, and stroke, because it can lead to a metabolic syndrome, which we completely ignore most of the times when we are seeing or investigation a woman with PCOS. What constitutes metabolic syndrome? Well, the various components of the metabolic syndrome are visceral obesity, high blood pressure, high blood sugar, low HDL cholesterol, and high triglycerides. I'm going to come to the diagnosis sooner, so I'm not going to go into the cutoffs which are given by various organizations and what we are going to use as the cutoffs for defining metabolic syndrome in our patients. But the components are visceral obesity, high blood sugar, hypertension, high triglycerides, and low HDL cholesterol. Let's keep this in mind. Well, at the center of this metabolic syndrome is the androgen excess or the hyperandrogenemia, which is seen in women with PCOS, and the insulin resistance and hyperinsulinemia. So let's quickly go through what androgen excess does and what are its implications. Well, let's understand what is the role of androgens in women. Women also need androgens, and even by the women, and they play a vital role in the functioning of many systems even in women. So the endogenous androgens which are present are either testosterone, dihydrotestosterone, androstenedione, DHEAS, and DHEA. In women, the source of androgen is from the ovaries and the adrenal cortex. Majority of them comes from the ovaries. DHEAS is the major pre-androgen, which is converted later into androgens. So for this conversion, there needs an aromatizable androgen. But these aromatizable androgens are converted into estrogen in the granulosa cells, and there are non-aromatizable androgens which cannot be converted into estrogens. Androgen receptors are nuclear receptor subfamilies, and they are expressed in several female tissues: ovaries, endometrium, brain, bone, breast, muscle, and heart. Let's understand what role androgen has to play in these different tissues. Well, the intensity of androgen receptor expression in the granulosa cells varies as per the follicles, and maximum is seen in the preantral or the antral follicle. About 7% of general population shows androgen excess, which could be in the form of identifiable reasons like non-classical adrenal hyperplasia, androgen secreting neoplasms, or hair-Ann syndrome. Or there could be non-identifiable, where we label them by exclusion, like PCOS and IH. Androgen, what are the effects of androgen excess on the metabolic syndrome? Well, there are two types of adipose tissues which we see: white adipose tissue and the brown adipose tissue. Now, what happens is, because of the hyperandrogenemia, there is redistribution of fat from subcutaneous adipose tissue to the visceral fat. So in women, basically that fat is seen in the subcutaneous adipose tissue, while in men it is seen more in the visceral. But because of the hyperandrogenemia, there is redistribution even in women. So more of visceral fat is deposited as compared to the subcutaneous adipose fats. Now, there is increase in the size of the adipocytes. There is reduction in the lipolytic actions, especially in the subcutaneous adipose tissues, leading to insulin resistance. Keep this in mind. Again, hyperandrogenemia leading to insulin resistance. There is decreased the secretion of adiponectin, which is an adipose-derived adipokine. Now, this adiponectin is an insulin sensitizer, and thus its decrease can lead to insulin resistance. So, in the white adipose tissue, hyperandrogenemia is leading to insulin resistance. What about brown adipose tissue? It is a specialized adipose tissue found surrounding the vital organs. Well, in liver, there is evidence suggesting that there is a clear association between PCOS and increased incidence of non-alcoholic fatty liver disease. Hyperandrogenism per se might increase the risk of NAFLD in women with PCOS. Positive correlation has been found between androgen excess and increased circulation levels of alanine aminotransferases, which is a biomarker for NAFLD. What happens in skeletal muscle? Again, androgen excess is associated with decreased insulin sensitivity at the skeletal muscle level. See, look at this. At every level, the insulin sensitivity is decreasing, which is leading to insulin resistance and ultimately is going to lead to hyperinsulinemia, which we will discuss. It also alters the intracellular insulin signaling, thus leading to insulin resistance. So even in skeletal muscle, it leads to insulin resistance. What happens in pancreas? It's not very well studied, but androgen receptors are found in the beta cells of the pancreas as well. In vitro studies have shown that defective insulin secretion to glucose stimulation and dysfunction of beta cells. Androgen promotes mitochondrial hyperfunction, oxidative damage, and insulin hypersecretion. Now, this hypersecretion by the beta cells of the pancreas over a period of time will lead to exhaustion of these beta cells, leading to decrease in the insulin secretion, leading to type 2 diabetes. In even the central nervous system shows that the hyperandrogenemia has a detrimental impact on leptin sensitivity at the central level and reduces leptin-mediated BAT thermogenesis. Such effects may compromise the weight-lowering properties of leptin. So because the leptin is reduced, the weight-lowering activity is reduced, leading to obesity, which is again one of the components of metabolic syndrome. Now, most of this hyperandrogenemia is leading to hyperinsulinemia, leading to insulin resistance in majority of the tissues of the body, which is leading to hyperinsulinemia. Now, what this hyperinsulinemia has to do? It affects the hypothalamus, the liver, the ovary, and even the other functions of the body. In the hypothalamus, it increases the GnRH pulse frequency and amplitude, increases the LH pulse frequency and amplitude. Again, this leads to increased secretion of LH, which in turn increases the secretion and synthesis of androgens by the ovary, leading to a vicious cycle. What happens in the liver? It decreases the hepatic production, leading to decreased SHBG. Less SHBG, increased levels of free testosterone circulating in the body, again leading to hyperandrogenemia and the vicious cycle. In the ovary, it acts through the insulin IGF-1 receptors. It decreases the IGF-BP1 receptors, again increasing the insulin quantity within the ovary. Now, we have to understand this, that insulin resistance is selective. When I say that it's selective, that means rest of the body, there is an insulin resistance, but the ovary still remains sensitive to the effects of insulin. It selectively inhibits the metabolic, but not the mitogenic actions of insulin. So this is very unique to the insulin resistance, which is seen in women with polycystic ovarian syndrome, which is exacerbated by obesity. Well, what this hyperinsulinemia has to do, what it does, that this insulin resistance in the adipocytes leads to increased shunting of free fatty acids from fat tissue to liver. Now, these free fatty acids induce hepatic synthesis of VLDL, increasing the VLDL, increasing the triglycerides and apolipoprotein B, and decreasing the HDL. So that's again one of the hallmarks of metabolic syndrome: decreased HDL and increased triglycerides. So that's how hyperinsulinemia is responsible for this decreased HDL and increase in triglycerides. What's the relationship between hyperinsulinemia and obesity? Where hyperinsulinemia leads to hyperandrogenism, leading to central obesity by the mechanism which we just discussed, redistribution of the fat from the subcutaneous to the visceral one. Hypertension and hyperinsulinemia. Hyperinsulinemia leads, it potentiates of sympathetic outflow. There is potentiation of the renin-angiotensin system, and all this leads to hypertension. Again, a component of metabolic syndrome. So hyperinsulinemia is responsible for the hypertension which is seen in the metabolic syndrome. Now, in addition to this, there is a concomitant endothelial dysfunction which leads to hypertension in women with PCOS who have metabolic syndrome. So that's just a flow chart which shows the insulin resistance and hyperinsulinemia in the development of metabolic disorders. What are the cardiometabolic consequences? Now we have this hyperandrogenemia leading to hyperinsulinemia. What does it lead to ultimately? Ultimately, it leads to cardiovascular disease. The risk of CVD and stroke are doubled in women with PCOS. Subjects with metabolic syndrome are 3 to 6 times more likely to develop coronary heart disease, with a 12% increase in the mortality. That is why metabolic syndrome is very important for us, because it leads to increase in the cardiovascular disease and the coronary heart disease. Metabolic syndrome confers a 5-fold increase in the risk for type 2 diabetes. up to 16% women with PCOS convert to IGT per year. Now, every PCOS woman may not be having IGT to begin with, but up to 16% of them will get converted into IGT per year. Over 6 years, the risk of progression of glucose intolerance to overt diabetes may be as high as 54%. And that is why hyperinsulinemia is important for us. That is why metabolic syndrome is important for us, because it may lead to type 2 diabetes in future. Now, is there a risk of cancer associated with metabolic syndrome? Well, an association between PCOS and endometrial cancer was first described in 1949. Real evaluation of the influence of PCOS on gynecological cancer risk should consider the causation of cancer and also the impact of the treatment used among these patients. The cancers which are studied are endometrial cancer, ovarian cancer, breast cancers, and others, of which the risk is maximum in endometrial cancer. There has been an association of endometrial cancer and PCOS. The risk is 2 to 6 times higher in women with PCOS, particularly type 1, most of which are well-differentiated tumors with a good prognosis. Data shows that a 9% lifetime risk exists of the endometrial carcinoma in PCOS versus 3% in the general population. Therefore, there is an increased risk of endometrial cancer in women with PCOS. What causes this endometrial cancer in women with PCOS? Anovulation, there is prolonged endometrial exposure to unopposed estrogen, which leads to endometrial carcinoma. Progesterone resistance, which is seen in the endometrium in PCOS. Therefore, the action of this progesterone is not existent on the endometrium. Hyperandrogenism, higher and disordered endometrial androgen receptor expression is seen. Hyperexpression of LH. LH receptors are overexpressed in the endometrium of PCOS, thus having increased action of LH on these endometrial cells. And insulin resistance due to the disordered glucose insulin homeostasis. Glucose metabolic pathways are dysregulated in the endometrium of women with PCO. These are the different mechanisms by which PCOS is or may be associated with the increased risk of endometrial carcinoma. Another important consequence of this metabolic syndrome in PCOS women is obstructive sleep apnea. It is associated, MS and PCOS is associated with up to 30-fold increase in obstructive sleep apnea and 9-fold increase in excessive daytime sleepiness. So all women with PCOS should be screened for and counseled about snoring, daytime somnolence, and fatigue. And if we find that she is having any of this problem, we need to treat her accordingly. Where psychological problems are also found to be more in women with PCOS who have got metabolic syndrome. Prevalence of depression is higher in women with PCOS with an odds ratio of 4.03 than the general population. This association is independent of the BMI. It's not because she is overweight that she is having depression. No, it's seen even in lean PCOS women. Inflammation is suggested to be the cause of depression, but exact cause is less understood. Then how to diagnose? Now we know that this is a very important part when it comes to metabolic syndrome. Now how to diagnose this? There are various organizations which have come up or put forth different criteria for the diagnosis of metabolic syndrome, like the World Health Organization, European Group, then the National Cholesterol Education Program, American Heart Association, International Diabetes Federation. However, what definition we as Indians have got to is that we define visceral obesity is more when the waist circumference is more than 80 centimeters, blood sugars more than 100 milligrams per deciliter, which is a fasting blood sugar, hypertension when the blood pressure is more than 130 by 80 millimeters of mercury, high triglycerides when they are more than 150 milligram per deciliter, and low HDL cholesterol when it comes to less than 50 milligrams per deciliter in women. The criteria are a little different for men. So for women, these are the criteria which are used for the diagnosis. And they say that any 3 of the 5 criteria should be present. NCEP says that. International Diabetes Forum says that 2 of the 4 criteria should be present. So there are various definitions which have been put forth, but this is the one which we normally follow in Indian women. Can we assess the risk of this metabolic syndrome when a PCOS woman comes to us? Yes, definitely there are certain parameters which should be screened at every visit or whenever is recommended. So what are these recommendations? Well, ask her regarding her cigarette smoking at every visit, obtain history of recent smoking habits, if any, or cessation. Obesity, weight, BMI, waist circumference should be measured at every visit. Blood pressure, again, at least for women with a BMI less than 25 kilograms, it should be measured at least annually. And for women who have a BMI of more than 25, it has to be at every visit. Complete lipid profile for women with a normal profile at the first visit, we can do it every 2 years. For women who have an abnormal profile in the first visit itself, annually it should be done. Now, oral glucose tolerance test with a 75-gram glucose for all women every 2 years, and women with risk factors like the age is more than 40, ethnicity, physical inactivity, smoking, waist circumference. For all these, it has to be done annually. Now, these are the recommendations for metabolic syndrome risk for screening in women with PCOS. All of us now should start screening our women with PCOS for presence or absence of metabolic syndrome and keep assessing them as per the recommendations. Well, how to treat? Now, there is, if we diagnose metabolic syndrome in time and treat it, we can lead to secondary prevention of the consequences which it leads to. At the center of this is the lifestyle modification. The diet and exercise are important components of healthy lifestyle. It is recommended that women with PCOS should lose anywhere between 5 to 10% of their body weight in the first year. Don't ask her to lose weight very fast. So it has to be a gradual process. Not more than 5 to 10% of the body weight should be lost in the first year after the diagnosis to improve the clinical outcome. Now, how should be a diet of a PCOS woman? Well, the constitution of the diet should be that the fat should form about 25 to 30%, carbohydrates about 40%, protein 25 to 30%, and fiber should be about 25 to 30 gram per day. Now, how to achieve this? The saturated fats should be less than 10. Increase the omega-3 fatty fats in intake, then decrease in the omega-6 fats. Optimal ratio of omega-6 to omega-3 is 4:1, which should be maintained in every diet, and include mono unsaturated fatty acids like vegetable oils, nuts, seeds, and avocado. Lean protein with low fat content is preferred, like chicken, meat, fish, and yogurt. When it comes to carbohydrates, low glycemic index foods are preferred, like bran, cereal, sweet potatoes, milk, and oatmeal. Non-starchy vegetables should be used. Fresh whole fruits should be used, and minimize the use of starchy vegetables like potato, corn, and peas. Good source yield is 3 grams per serving for a fiber like a whole wheat, rye, or oats. That is how the balanced diet for a PCOS woman should be to avoid metabolic syndrome. Now, how lifestyle changes affect that? Decrease in the weight, decrease in the waist circumference leads to decreased hyperinsulinemia, decreasing the hyperandrogenism. The hormonal balance is restored, and thus ovulation can also take place. Well, we can supplement these lifestyle modifications with medical management. What are these? Insulin sensitizers. Metformin is the one which improves insulin sensitivity in women with PCOS. It decreases fasting insulin levels even in non-obese women. So use of metformin for lowering insulin resistance should not be recommended in normal glycemic women. So it should be only for those who have got hyperglycemia. Women with impaired glucose tolerance can be prescribed metformin to prevent progression to type 2 diabetes. It also it is used in the incremental dose of 500 to 1500 milligrams per day. It also helps in weight loss, but it should not be prescribed for weight loss. It should be in association with the lifestyle modifications, not primarily for the weight loss, but primarily for the impaired glucose tolerance. Ionositol, Manjiri just said that there are two isomers, myoinositol and D-chiro-inositol. Well, D-chiro-inositol reduces the basal insulin levels, and therefore lean PCOS women with hyperglycemia should be given a combination of MI plus DCI rather than just giving myoinositol. Now, it is given in the dose ranging from 1 to 4 grams per day, and if we are giving a combination of myoinositol and dichloroinositol, it should be in the ratio of 40:1. Now here one point I want to emphasize is that when we are saying 40:1, 40:1 is also ratio 40:1, 80:2 is also 40:1 ratio. So what should I be preferring? So my myoinositol range should be between 1 to 4 grams, and then accordingly my dichloroinositol should be in the ratio of 40:1. But there is a minimum dose of myoinositol which is also needed. 250 milligrams of myoinositol with an 40:1 dichloroinositol is not going to serve my purpose, and therefore we have to be very careful when we are prescribing this MI plus DCI combinations. Look at the MI dose which is present in that tablet, and then prescribe accordingly, because the range of the MI to be given per day is between 1 to 4 grams per day. Majority of the studies have been done with 4 grams, and very few studies have done with 1 or 2 grams of myoinositol. When it comes to anti-obesity drugs, orlistat is the commonly used one. It is an irreversible gastric lipase inhibitor that prevents breakdown of dietary fat and thus its absorption. It also improves lipid profile by significantly reducing the total cholesterol, LDL, and triglycerides. It is taken in the doses of 60 to 360 milligrams in 2 to 3 divided doses. However, there are certain gastrointestinal side effects like steatorrhea and abdominal pain, but most of them are tolerated well. So this is the first line of drug which is used. Another one is liraglutide. It is a glucagon-like peptide receptor agonist. Significant reduction is seen in the BMI, but not much change in the waist to hip ratio, which is more important for us when it comes to metabolic syndrome. There is no significant effect is seen on the insulin levels and insulin resistance. The use is limited, and larger studies are required before we can start prescribing liraglutide very often. Statins in women with dyslipidemia, statins significantly and consistently improve the lipid profile. So if we have a PCOS woman with dyslipidemia, maybe we can think of prescribing her statins. It also reduces the endothelial dysfunction and systemic inflammation, thus reducing the risk of CVD by lowering the blood pressure. Long-term use may cause liver dysfunction and can lead to teratogenicity. So whenever we are prescribing statins, we should counsel her that she should not get pregnant and use some contraceptive to avoid pregnancy. Long-term, as I said, because of the liver dysfunction is not very recommended. So routine clinical use of statins is not well recommended. Well, surgical management constitutes a small part of the treatment for metabolic syndrome. Bariatric surgery is the mainstay. It is done when there is difficulty in sustaining the lifestyle alterations to reduce the weight and where other management strategies have failed. So in whom should I be doing these bariatric surgeries? Well, they should be done in class 4 obesity, where the BMI is more than 40 kilograms per meter square, or in class 3 obesity, that is the BMI is between 35 and 39.9, but it is associated with chronic medical conditions like diabetes and hypertension. So what kind of surgeries you can do? You can do a sleeve gastrectomy, which is the most commonly done, Roux-en-Y gastric bypass, then laparoscopic adjustable gastric binding, and biliopancreatic diversion with duodenal switch. So these are the various kinds of bariatric surgeries which can be performed. There are certain thresholds which have been proposed by different societies for doing a bariatric surgery, like by the Australia and New Zealand OBGYN Society, the threshold is 35. By UK, it is between 30 to 35. And in the USA, it is taken with anything between 35 to 45. So this is the surgical treatment which we can do in women with obesity to reduce the chances of metabolic syndrome. Now, that's just a flow chart of how to go about the treatment of metabolic syndrome. So to friends conclude, metabolic syndrome is a neglected entity. Multiple mechanisms have been proposed in the evolution of metabolic syndrome. Hyperandrogenemia and hyperinsulinemia remain the hallmark. It is imperative to implement recommendations for early diagnosis and institute aggressive measures for secondary prevention. We all are treating our PCOS women for infertility. Let's get into the habit of investigating them even for metabolic syndrome. And whenever necessary, let's institute the aggressive measures or treatment to reduce the chances of consequences like the cardiovascular disease or diabetes mellitus or stroke. Thank you so much for your patient hearing. And again, I would like to thank Dr. Monica and Dr. Jyoti for giving me this opportunity. I hope I have covered the entire thing. It's quite a vast topic though. Thank you.
Thank you so much, sir. Over to Chairperson Anjali Ma'am Magar, sir. You want to sum up or say something?
Thank you very much, Dr. Chaitanya, sir. It was a very elaborate lecture, all about the metabolic syndrome. Thanks a lot.
Thank you, ma'am.
Thank you, sir. Now we are moving towards our exciting section, that is panel discussion, adolescent PCOS. I welcome our moderator, expert moderator, Dr. Varsha Baste ma'am, and co-moderator, Dr. Priya Shinde madam.
Hello.
Actually, we were waiting for Varsha ma'am because she, in spite of being busy, she managed. Yes, ma'am. Thank you so much, Dr. Varsha ma'am. She is practicing gynecologist in Nashik since 30 years. She is director of Baste Maternity Hospital and Pushpa Fertility Center. She is of Cell Gene Anti-Aging Stem Cell Center. First ICSI and PGD baby in North Maharashtra. She was past president of OBGY Society Nashik, chairperson of Foxy IC. She got prestigious Dr. Anandibai Joshi Award and organized many national international conferences. She participated in numerous national international conferences and has few publications to her credit. Thank you, ma'am. Next is Dr. Priya Shinde, ma'am, as co-moderator. She is consultant obstetrician and gynecologist at Shinde Multispecialty Hospital, Chandrapur. She is secretary Chandrapur OBGY Society. She was ex-lecturer Savangi Medical College, Varda. Foxy.
We can start, madam. Thank you very much. We can start because Basta madam may get some disconnection after this.
Yeah.
Thank you very much.
Thank
you very
you so
much.
much. And Dr. Priya, can you share the slide?
Yes,
physically?
madam.
Yeah.
Yes, madam.
And then I will talk to you. Thank you, organizers, Monica, Priya, Jyotisul, and all AMOGs, budding active members and Foxy leaders also, and AMOG leaders for giving me this opportunity to conduct this panel discussion. The problem is I am at the airport and I have to catch the flight, so there will be some disturbances. I will talk loudly. So my topic is adolescent PCOS case-based panel discussion, and we have to invite the esteemed panelists. The previous talks were excellent by Manjiri and Dr. Chaitanya, and they really gave us all the inputs about this panel discussion also. So I really enjoyed their talks also. So can you put the slide of the panelists, Priya? Adolescent PCOS is a burning issue now. It is a major issue. Every alternate patient of the girl who comes to us with a problem of hirsutism, acne, menstrual irregularity, and we have to treat them, and counseling is most important. So our the panelists are none other than Dr. Kishore Artutkar, Dr. Supriya Arwari, Dr. Rachana Jaju, Vaishali Surase, and Nagina Naidu. Welcome you all, esteemed panelists. So, what is PCOS? The Rotterdam criteria is the most commonly used criteria to diagnose the PCOS, because there should be clinical hyperandrogenism, which is the score is FG score more than 8. It was postulated in 1990-2009, but now the score is 4 to 6. And biochemical hyperandrogenism should be evident. Oligoamenorrhea less than 6 to 9 menses per year, and oligo-ovulation. And also, this polycystic ovary should be seen on ultrasound more than 12 antral follicles, or ovarian volume should be more than 10. Next, please. So this will tell us about the diagnosis of PCOS. What is the clinical picture? That is also very important. We can see at one look at the girl, and you will know She is having PCOS on sonography. We can see all these follicles segregated at the periphery. Gandamay म्हणतो ना तसं, because the inside stroma is thick. They are all apoptotic follicles, and they secrete this androgen, and that is the main cause of our problem with the PCOS girls. Mood disturbances, depression. Oh, then there is acanthosis nigricans, insulin sensitivity, obesity. Then there is acne, different kinds of acne, mild, moderate, severe, and there is hirsutism, irregular bleeding, and alopecia. Because all these because of androgenic effects. Next, please. So 4 different phenotypes of PCOS are now identified. Type 1 is hyperandrogenism, chronic annulation, and polycystic ovaries. Type B is hyperandrogenism with chronic annulation. Type C is hyperandrogenism with polycystic ovaries, and type D is chronic annulation and polycystic ovaries. So hyperandrogenemia is the hallmark and the mainstay. You have to treat that, and that is causing all the problems. So clinical expression of polycystic ovarian syndrome in adolescent girl is very, very important, and what it is. Next, please. The oligoamenorrhea or amenorrhea for 2 years after menarche, clinical hyperandrogenism and persistent acne, severe hirsutism is evident in such cases. Biological hyperandrogenism, that is plasma testosterone more than 50 nanograms or increased LH-FSH ratio more than 2. Insulin resistant hyperinsulinemia, acanthosis nigricans, abdominal obesity, glucose tolerance is seen, and PCOS on USG. If 4 out of 5 criteria should be present, then it is the diagnosis of adolescent PCOS. Let us see next case. Next slide. So all these 3 criteria of Rotterdam should be met for the diagnosis that we have just seen in the first slide. Next. So let us see from the case, we will discuss the cases. On 2 cases mainly I have taken, like acne with hirsutism, and another is with menstrual irregularity. There is so much of noise disturbances. Dr. Priya, can you take over from the cases, please? Thank you for giving me this opportunity. Thank you all for giving me this opportunity. Love you all.
Thank you, madam.
Have a safe flight, Varsha ma'am, and enjoy your trip to go Turkey.
Yeah. Thank you. अरे चाय शायरी हो जाए, चाय पी लो. Thank you all. Bye.
Thank you.
With your
So to start with the cases, case 1, she's 18-year-old. She's came in the OPD with complaint of hair growth on face and chest, scalp hair loss, pimples leading to scarring over face. Her menstrual history, she has attended menarche 6 years ago. Her cycles are 3 to 4 per 35 to 40, and she's unmarried and sexually inactive. Her height is 150 centimeter, weight is 78 kg, vitals are normal. She's having male type alopecia, facial hair on chest is noted, and pimples noted. So this question goes to Dr. Kishore sir. How will you proceed in this case? Sir is there?
Yes.
Yes, sir. Welcome, sir.
Thank you. So in this case, but or for that matter, in any case, we'll have to go for. We have given history now. It is clinical examination is first step. And obviously, we can see that the BMI is almost 35 in this case, and the cycles are irregular. So we have to investigate in the manner of routine investigations to begin with, like CBC. And
also by history, sir. Also by history, we can go with if she's having family history. By history.
In history,
what do you want to specify in this case?
We must ask the family history, and is there any history of PCOS in the family? That is a very significant point. Secondly, her routine. What she does since morning to evening. her dietary habits, then whether she is doing exercises or not, and what she is, in which education she is into. You have to look into all these aspects, not only her body and chemical, but her family background and her social background, her educational aims and objectives also looked for. So that would be a holistic approach. And
By
then
history, yes, sir, by history, we will start with the history, and then on physical examination, you said the BMI is more. Then how is the fat distribution in this case? And then we will try to assess this hair distribution, because she mainly came with the worries of acne and excessive hair on the body. And then we will try to classify according to the Ferryman-Galway score, because she is worried more with for the hirsutism and the acne.
Yes.
Then we will see in this case, and we will try to score the patient according to this scoring system. Do you want to highlight this slide, sir?
Hello.
Yes, sir. This is the scoring system in these 9 body areas. Yeah, who is there? Dr. Kishore, sir, would you like to highlight this slide in the to have this score for this patient? Kishore, sir?
Oh. Yes.
Would you like to highlight this slide?
Yes, madam. This is a slide of hair distribution, and I'm really the score appears to be more than 4 to 6.
Yes.
So it shows the signs of hirsutism.
Yes.
Sir, farewell there. It is FG way of classification according to the hair distribution on different parts of the body.
Hello, Priya. Hello. Priya, you're muted.
My slides are hanged, madam. Just a second. Just a second. Ma'am, can you please elaborate this slide? This is very important.
Sure. Actually, I wanted to make a comment here. The modified Ferryman-Galway score is definitely a good way of grading the hirsutism, where we give particularly attention to the male pattern distribution of hair. That is hair on the face, hair on the medial side of the thighs, hair around the areola, hair on the abdomen. So these are the sites which are normally not, female type of hair distribution. But here a word of caution is that this score has to be interpreted very carefully, because there are a lot of ethnic considerations, racial considerations. For example, Indian races are originally, to start with, are more androgenic. So we have to be very careful when we are grading. Secondly, how much the hirsutism disturbs that girl is equally important. Some girls may be very comfortable with maybe a little moderate grade of even hirsutism, but some girls may be extremely sensitive to even very mild hirsutism. So patient preference and how much it is disturbing her mentally, physically is also to be given equal importance. Score more than 4 to 6 is definitely suggestive of hirsutism. And obviously this case we are distressing because hirsutism is, that is the androgenic part of her, PCOS syndrome, the symptoms of the syndrome. There can be additionally other forms of, there is some echo. Has someone signed up from 2 devices? Hello?
Yes, sir, it's clear now.
Kishore sir, we'll have to disconnect one device because there is echo. Yeah. So what we need to also look for other signs of hyperandrogenism like acne, like hair loss, alopecia. Alopecia can be female type of balding. It can be male type of balding. So that is something that we need to be watching out for. Acne, whether they are mild, moderate, severe, whether they are infected, they are inflammatory, comedonal, that is what we would be considering, because all this will dictate the type of treatment that we'll give her. If Kishore sir has signed up, then maybe he would like to make a comment. Sir, please sign out from the other device.
Kishore
Sign out
sir,
from your mobile.
Yeah, ma'am, I have muted, sir.
Yes,
You can
yes,
continue,
yes.
please, ma'am.
Yes, ma'am. No, sir can go on if he wants to. Sir, would you like to add something? Kishore sir.
we can proceed to the
Well, I
investigation.
did that.
Okay,
I was facing some audio problem with my laptop, and therefore I had to catch my audio from my mobile. But it's okay now. I have disconnected my mobile, and well, I am with you, and all this clinical examination and the importance of clinical examination you have elaborately actually explained. So I need not repeat all the. Thank you very much.
Thank you, sir. Thank you.
Thank you, Dr. Kishore sir. Now, Dr. Supriya ma'am. Now she is the case of this hirsutism and acne, and she is now 18 years old. How will you want to investigate this case? You want to rule out any other diseases for this?
Definitely. First and foremost, we will be doing all the basic workup of a girl who has this kind of, obvious hormonal imbalance and androgen excess. For that, first and foremost, we will be doing her basic screening like a CBC, like a thyroid investigation. We should not forget that often, thyroid hypothyroidism can accompany other, hormonal imbalances. So that is something of fasting and postprandial sugar level. Although madam's lecture, she very rightly said that FBS, PLBS nowadays, at least in the adult group, is not so relevant. We do an OGTT, but personally for a young girl, adolescent girl who's coming to the clinic, I would not be, straight away exposing her to a OGTT. Practically, I would still prefer to do a fasting PP level to make sure her sugars are normal. Definitely serum insulin has no place now. There are other ways we can make out hyperinsulinism and insulin resistance. Since this is specifically a case of hirsutism with acne, meaning the androgenic excesses, we would definitely like to rule out things like congenital adrenal hyperplasia or something like adrenal tumor, adrenal, this androgen secreting tumors. So for that, we would like to do her testosterone levels. A free testosterone more than 200 would definitely suggest something like a tumor or a virilizing tumor specifically. And she might also have these signs of virilization. And here is what the next point comes, that when we are examining adolescent girls, often we shy away from doing a local, examination of our private parts. That is not what we should. We should definitely ask them to give them due privacy, take them into confidence, and do a thorough examination, including examination of the private parts. We would definitely be able to make out clitoromegaly. If it is associated, we can also make out the pattern of hair distribution in the pelvic area, or more specifically in the pubic area, medial side of the thigh. We would also, a young girl coming with certain symptoms, want to make sure she doesn't have any local injuries, or whether she's sexually active or no. Such a lot of information is gathered by examining her private part. So that is something that we should definitely be doing. We will do a DHEA and a DHEAS, free androgen index, basically to make sure we are not dealing with something other than just hyperandrogenism associated with a young girl of PCO. So this is, I think this will in short. Now there are various modalities by which the laboratory people do their hormonal assays, and although mass spectrometry is the best way, usually what we get is the radioimmunoassays or the chemiluminescence immunoassays. So these are the various ways in which we can investigate her, evaluate her. Yeah, definitely sir has already covered the history part. Laboratory investigations for particularly for DHAS I have already mentioned. And like I already said, we should be little careful when we are interpreting the modified FG score, because ethnic variations are there, and we should also ask for history of hair removal. If suppose she's removed her hair from the chin, then when we examine it, not going to be anything there. So that is one thing in the history that we would like to do. Thank you.
Yes, very rightly said, Dr. Supriya ma'am, and you have covered all the topics, how to investigate the case and how to proceed with the clinical diagnosis also. Now we will move to how will you treat the case. Dr. Rachna Jaju ma'am, are you there?
Can I just make one point here? Just excuse me, just one point that I really forgot and is important is in this case, maybe you would like to do an ultrasound examination for the girl, abdomen plus pelvis. Number one, abdominal examination to make sure we are not, missing any suprarenal tumors, and clinical and a pelvic examination to make sure there are no ovarian tumors. There can be some ovarian virilizing tumors. So this is something that you will like to rule out on ultrasound, but be extremely careful to label a young girl as a PCO just because there is polycystic ovarian morphology in the ultrasound report. That is, I think we'll come to that later, but this is just one point I want to make here. Thank you.
Yeah, thank you. Dr. Rachna Jaju, how will you treat the case now?
Good evening, all. And moving toward the treatment part, now we have seen in the case that she's an 18-year-old girl, and the body weight was suggestive of 78 kgs. So in this case, counseling plays a major role. And in our busy practice, we don't give due time to such patients, and we just try to avoid them, or we just rush in and say some few words and then we move ahead. But I think that polycystic ovarian patients, especially young girls or who are planning for infertility, should be given a separate time in our OPD for counseling. We should think of giving an evening hour for them so that we have a proper counseling session with them. And counseling of not only the girl but of the entire family is important, including her mother and her family members, that she's going through this particular thing. There are variations in this. There are psychological factors. She might be having slightly some sort of anxiety or depression. So counseling of the entire family along with the girl is very important. This is the first and foremost thing. Second is, in these patients who are young, say 18 years of age, and are not planning for any, she's not planning for any infertility treatment or anything, then here lifestyle changes are of very much important. Here we emphasize her on a good healthy diet. Ganapure sir has shown a very good chart of what the diet should include, which includes say 40% of carbs, 20 to 30% of fats, proteins and fiber. So that has to be explained to her along with the help of the nutritionist, the way she's going to have her diet. Exercise plays a very important role because the major part of polycystic ovarian management consists of dietary changes and exercises. So half an hour to 45 minutes of daily exercise, vigorous exercise, and not just routine exercise is what is recommended. And usually these girls do tend to have, nowadays major girls do tend to have a less sedentary life where they don't do much of a work, so they should be involved in household activities that involves their physical activity. So this plays a major role. And as I had said earlier, there will be changes. There will be changes of anxiety. There will be changes of depression. There will be changes of the way the girl looks at herself. The hirsutism part will be annoying for her. So behavioral changes will be there, and the family members and the people around her are to be supportive to her. So these are the changes which are recommended. Apart from lifestyle changes, we go to pharmacological treatment, wherein we can use metformin as an insulin sensitizer. We can use myoinositols, D-chiroinositols. They will take care of the polycystic part. And if at all the girl wants to have regular periods, then we can go for treatment part. So that will include combined oral contraceptive pills.
Here we are worried for the acne and hirsutism.
Yeah.
And her cycles are around 30 to 40 days. So we want to treat her for these two things now.
Yeah, so for acne, she'll be having topical applications, antibiotics, retinoids or benzoyl peroxide. And for hirsutism and acne, both we can recommend combined oral contraceptive pills. Usually we go for third and fourth generation of progesterones. because they have more of anti-androgenic activity as compared to the first and second generation of progesterone. So we will preferably use ethinyl estradiol along with desogestrel or ethinyl estradiol along with drospirenone. That will be the drug of choice, because as it is written in the slide as well, that estrogen will inhibit the conversion of testosterone to a potent dehydrotestosterone, and progesterone will also reduce the anti-androgenic activity. So for acne and hirsutism, we go for that. But cyproterone acetate is also known to have good effects. It has to be given with caution, but can be used, and it will reduce the hirsutism part to a significant extent.
Yeah. And if it is resistant, if it is patient is still worried, if she's taking since 6 months, we can go for with the anti-androgens also.
Yeah, we can add anti-androgens, and we can go for cosmetic corrections for this patient. We can recommend them lasers, bleaching, waxing. So this will also help her to improve her facial appearance, and she will have a sense of confidence if she develops, if she undergoes all this treatment.
Yes, yes, very rightly said. Just yesterday we had attended UA Foxy, and Dr. Mane sir very rightly said 33% counseling, 33% lifestyle changes, and then 33% of medicine works in the case of hirsutism, acne, and the PCOS. Thank you very much, Dr. Rachna.
Thank you, ma'am.
Now we'll go with the case 2. She is 20-year-old girl. She's having irregular menses since 2 years. Her present menstrual history is 6 to 7 days, and she is getting per 2 to 3 months. Past history, she was having regular after menarche. She's attended menarche 8 years ago. She's unmarried, but she is sexually active, and she is using barrier contraceptives. Her weight is 50 kg, height is 162 centimeter, vitals are normal, she is mild pallor, per abdomen checkup is soft, cervix vagina is healthy, and per vaginum is uterus and antiverted normal size. So my question is with Dr. Vaishali Surse.
Yes, ma'am.
How will you proceed in this girl who is 20 years old and her periods are irregular, and she has come in your OPD with a normal, her weight and this height is 162, weight is 50 kg. How will you proceed in this case?
Yes, good evening, ma'am. Thank you for the opportunity. Ma'am, first of all, we should always remember that nowadays we get a lot of cases who are sexually active and who have a history of irregular menses. So we should always rule out a pregnancy in such kind of cases. After ruling out the pregnancy, we should always remember that she is not actually adolescent, but she is around 20 years. So we should remember that the hypothalamo-pituitary ovarian axis takes some time to mature. It may take around 3 years in some of the cases. The irregular menses in her may be a natural physiological phenomena specifically in the adolescent age group. Then after ruling out the pregnancy and remembering the important thing of maturation of the axis, then we should go and think about the differential diagnosis of this case. What may be the reason that she is having irregular menses? It may be primary or secondary hypothalamic amenorrhea, most commonly associated with polycystic ovarian syndrome is the hypothyroidism and hyperprolactinemia. So we always have to rule out that. Then another uncommon causes may be the congenital adrenal hyperplasia, androgen secreting ovarian or adrenal tumor. Then we have to investigate her and try to come to a diagnosis. First of all, as she is in the OPD, we usually, if she is sexually active, we do a transvaginal scan and we look at the ovaries. But again, in the adolescent, the ovarian picture may not be that confirmatory, because in most of the adolescents, they do have multicystic ovaries, and it takes time to actually form the peripheral ring of the immature follicles. So hence, but again, we do a ultrasound to rule out the pregnancy, and if it is a classical case of which shows a polycystic morphology, we can see to it.
Then we do her prolactin and TSH levels. If she's having amenorrhea, we can do it any time of the cycle. And the total and free testosterone, DHEAs, 17-hydroxyprogesterone. And then if she's within the first 2 to 5 days of her menses, we do the FSH and LH levels also. If the ratio is deranged, then we can come to a conclusion. Specifically, I would like to mention here that in cases, most of the cases of polycystic ovaries, we do the AMH levels, which is confirmatory, we say. But in specifically in adolescent age group, the AMH is seen to be higher with the polycystic ovaries, and there can be a significant overlap in the levels. AMH should not be used as an alternative for detection of polycystic ovaries, specifically in adolescents. Other tests like, as Dr. Manjari ma'am has said, that we do OGTT. We can do a lipid panel and a fasting insulin to rule out the metabolic syndrome as well.
Yes, very rightly said, and you have covered all the topics. How will you proceed and how will you investigate the case? Now my question to Dr. Nagina Naidu. How will you treat this case who is now, madam has labeled her as PCOM?
Foremost, thank you everyone, especially Jyoti Sool ma'am and Latu team to give me the opportunity. And my question is the repeated one. I had already heard about it at Jabalpur yesterday only from Mane sir. And after seeing Supriya ma'am, I am feeling as if I had not left Jabalpur still. I am at Jabalpur still there. Yeah. And the answer would be already told by Rachna madam in very detail, and already Sool madam said the Rajdhani Express, she has taken all the points in it with the lifetime changes, the proper counseling, what exactly up till now we had heard and learned. Apna size pehle kam rakho so that you can motivate the patient more. And the second thing is, nowadays parents are very much concerned about the career of the children. They are like bas pado and pado. Definitely they are not into in the physical activities of children. They are not at all concerned. They are only concerned about the career. Whenever the patient comes to me, I just motivate them by saying, have a 45 minutes of walk or whatever the way of exercise you can do at home only. If you're getting a phone call, just walk and talk on phone. Don't sit and sleep and while doing that thing. With that, help your mother regularly by bringing the clothes, going on the steps 5-10 times. This routinely at home only you just try, but modify your way of doing the work by helping your parents, so that at least that will be helping your metabolism. And with that, pharmacological treatment, already Manjari ma'am has very clearly covered it. Lifetime changes, I had already told you. And the behavioral changes is, I'm busy. All say I'm busy, but you have to bring out your time to be normal. And regarding pharmacological treatment, what we can cover, that is OC pills, the metformin, anti-androgens, already again covered by Rachna ma'am. I don't want to repeat the things. I just want to say we have to do the proper counseling as already told by Priya ma'am. 33%, 33% and 33% is a very apt formula to conquer the disease.
Anyone has any experience with this DVT in young girls with OCPs?
I don't have up till now.
Even I have never seen a case of DVT, but I personally prefer the progesterone combination, pure progesterones much more in the younger girls, for this very small concern that the estrogen that is present, especially very young girls, it can accelerate the epiphyseal fusion. And that's why we have to be a little wary when we give combined pills. I usually prefer to give, now we have these good progesterone, sustained release preparations, and they give equally good result as well as far as cycle control is concerned. So that is one option that we can always think of, giving norethistrone sustained release instead of oral contraceptives, especially in young girls.
Very nice tip, madam. Yes.
This case, as she is sexually active and she is already using barrier method, and very soon she went into active sexual life. Definitely, we should suggest her the vaccine. She require it more. It is a very dangerous thing for her. We should counsel her properly regarding the vaccine too. With that, she have to take good care regarding the contraception in this case, especially.
So something I have heard, like if the girl is obese and if she's having given OCPs, then I think some case was also there over the doctor for this DVT thing.
Yeah, we have to be very careful.
So they
Yes,
have
I
to be
agree.
very careful in this young girls if she is obese also to how to and when to prescribe the OCPs.
Absolutely. And it's actually, there is no answer to it. It's a tightrope walk, you know. You don't know which patient is going to land with DVT. There have been some cases where even the cerebral venous thrombosis women have complained of. Although I've never heard in young girls, but in my own friend circle, I have had my friend who got a sinus thrombosis in the brain. So very, very carefully we have to suggest. I do agree.
Yeah. So we'll move to third case now. And I think Dr. Supriya ma'am will cover this case very well. She's 17 years old, studying in standard 12, was a national level basketball player, used to practice for 3 hours a day. But she stopped playing and gained 30 kg in 9 months. Her LMP is 3 months ago and her past history were 4 per 28 days and regular. She is not sexually active. Her height is 170 centimeter and she is now 97 kg. Her vitals are normal. She has slight facial hair growth and acanthosis nigricans and truncal obesity. So, how will you go with this case, Dr. Supriya ma'am?
Okay, by the looks of it and the description, definitely this falls in the category of metabolic syndrome associated with PCOS. And Dr. Ganpule's lecture has made my job actually very easy. He has really elaborated in a very fantastic fashion how to go about this metabolic syndrome. I would like to concentrate on the nuances in young girls. If we are talking about particularly adolescent girls, now we know metabolic syndrome basically consists of obesity, hyperdyslipidemia, and insulin resistance. Here, obviously, this girl is now some 97 kgs. BMI is just through the roof. And again, now what the past panelists have said will all again come true. First and foremost, lifestyle modification, exercise, diet, most important. Investigation wise, if she has a glucose level more than 100, if she has triglycerides more than 150, and especially HDL less than 50, then we would be very considerate, and hypertension, more than 90th percentile for her age, for the female population. This will all go in favor of the metabolic syndrome. And out of all these various 5 criteria, any 3 out of 5 is supposed to be the diagnostic hallmark for metabolic syndrome. We were talking about diet and exercise. In exercise, the first thing about diet and exercise we need to stress is that the family should be involved in the lifestyle modification. You cannot have the mother and father eating samosa and asking the poor girl not to eat samosa. Samosa should not arrive at the residence is the first advice that I give. That stop bringing high calorie stuff at home. Everybody eats a healthy diet. A diet which is made of the regular food that is cooked at home. We don't want exotic foods coming from US and UK. The regular food that is available in your neighborhood, make sure it is a low calorie, cook in less oil, keep carbohydrates to the minimum, and the entire family should be eating healthy and exercising. As many a times this is a family thing. The mother is obese, the father is obese, and they want the child to go do exercise when they are doing nothing. We ask the mother to get up early, go with the girl, do some exercise, go simple walking 45 minutes daily without fail is good enough for exercise, a good enough exercise for weight loss. Over and above that, whatever exercise she wants, she can definitely do. The same way for the diet and the exercise. Suppose now children usually complain that usko classes hai, usko college hai, she has no time. Then that diet should and exercise should be incorporated in her routine work. She should carry a tiffin which has salads and fruits, and she should walk to her college or school and walk back so that the exercise becomes part of her routine. She doesn't have to take out extra time, which she probably doesn't have for doing that exercise. These are some very important practical tips that I give to my young population. Next, if we are now talking about the medical management, that metformin, without a doubt, has been shown to have extremely beneficial effects, especially where now in PCO we have, central obesity. They have a big tummy. The hips, waist to hip ratio is something that really very difficult to do in a busy practice. But at least height, weight, and waist circumference is something we can measure. And such girls who especially have truncal obesity, metformin will do them good. It will help in regularizing their metabolic imbalance. It will help in regularizing or reducing the insulin resistance, and help them in the weight loss, and also help in regularization of cycle. Doses around 1500 milligram to be given in divided doses. We are usually worried now that there was this talk, if you remember, Priya, by Dr. Parikshit Tang. Very beautiful point he brought out. Sometimes we are worried in lean PCOS to give metformin, worried that it can cause hypoglycemia, but actually they are the ones who will respond better to metformin. All we need to do is counsel them that if in case there is a little hypotension, hypoglycemia, some sweating or weakness or fainting, the patient and her attendant should be told, give her sugar water or something like that, And in addition, we can definitely give her oral contraceptive pills if there is a lot of irregularity in the menstrual cycle. COC with metformin have shown to have a conjunctive effect in treating metabolic syndrome. So that is something that we would definitely recommend. Now there are a host of inositols and D-chiroinositols. Madam and sir have gone at length about it. So there is nothing much that I can add. Although yes, there is a role. I personally do give a lot of those. A combination of both myoinositol, D-chiroinositol is basically the drug of choice for especially metabolic syndrome. And there is one thing that I had come up was very beautiful slide when I was preparing for my talk on diet for PCOS. There are certain food items which give natural myoinositol. So that is what we can recommend, like cantaloupe, what we call kharbuja. It has got a lot of natural myoinositols. So that is something we can recommend. There are some certain nuts and dry fruits which contain natural myoinositol. So that is something we would like to recommend to our young girls.
Very nice.
Also, jaggery also contains natural myoinositol.
Yeah. So these are some things we can recommend, and diet and exercise without fail, and something that is realistic. You start with giving them goal of reduction in 10% of the weight. You don't tell them reduce 25 kilo. They will never do it. Tell them you are 87 kg, lose 8 kg and come back. Then we will talk about the next. The stress has to be given on the fact that it has to be persistent. Weight loss is not going to take place in 2 months. It sometimes takes 1 to 2 years. And often in 2 months, they don't lose weight. They become very disheartened. So counseling is extremely important, and keep doing it for next 2 years. And you will definitely go 3 sizes small. That is something that is very attractive to young girls, to look slim and wear small size clothes and, wear something that they really want to but can't because they are fat. This I'm telling for experience. So something like this, to boost their morale, we should be always, telling them these things. Yeah, thanks.
Thank you, ma'am. Today my OPD only, there is 100 kg girl who was 15 years old. And she came after 1 month with a loss of 5 kg. Yes. So I asked what you did in this last 1 month. The mother said she is going by, without scooty, she is going to her tuition class.
Yes.
So 5 kg in 1 month is a very pretty
excellent.
Good
And never forget to compliment your patients. Just tell them, I'm so proud of you. That will help them lose the next 15 kg. So always compliment your patient for whatever little effort. Sometimes we are very judgmental, I feel. That क्या है 5 kilo हुआ है अभी तुमको 50 कम करना है. Don't ever make that comment. Say, I'm so proud of you. 5 kgs you have done. Next 15 kgs will go like this. So next time she'll come with another 4-5 kg.
Yes. It was a very good result. 5 kg I have never expected from that young girl of 15 years only. But it's a very good result.
Yes.
So here now, this is a slide with adolescent at risk. Madam has rightly said, if menstrual irregularity or the features of hyperandrogenism persist beyond 3 years post-menarche, PCOM 8 years post-menarche, they should be explained about their at-risk status, and follow-up is needed to diagnose PCOS at later stage. So I conclude here with the slide. The diagnosis of PCOS in adolescent is difficult owing to its overlap with physiological events. Hyperandrogenism is often the most reliable finding in this age group. The current epidemic of childhood obesity may increase the severity of PCOS, and identifying the adolescent at risk is equally important, and follow-up of such girls is warranted. The slides were prepared by Dr. Varsha Bastar Madam, and she has given the opportunity. So I thank from my side to the Varsha Bastar Madam, and very nicely covered by all the panelists. The topic was very crisp, and you have covered in a very, I should say, very crisp and clear messages. Yes, yes, Dr. Kishore sir, you want to add here also?
No. We should be able to give a correct message after this panel discussion about when to start the evaluation.
Yes.
We
So,
are
so
dealing
the
with
slide of this adolescent,
very young girls,
yeah.
young girls who are usually in 10th class, 11th and 12th class, going for NEET exam and all that. And we should decide, we should be able to decide because we are talking about battery of investigations, and that itself may cause concern into her studies. So
no, the guidelines have come, sir.
We should be able to decide when to start the evaluation. Because
so now the guidelines have come for this adolescent PCOS.
They are little away from their reproductive career.
I want to add, sir, now the guidelines have come. Like we don't have to label the case of young girl before 18 years. She is a case of PCOS. For 8 years after her menarche, we can wait for labeling her PCOS, because if we label her as PCOS, she is always the case of PCOS. So to develop this maturity of the axis, we should wait for this 8 years gap are there. And there are very beautiful guidelines of some 84 pages are there on this adolescent PCOS.
Secondly, mother should be, Dr. Supriya has really talked about counseling the entire, and even Dr. Jaju also has emphasized the importance of counseling the whole family. But it should be mother who should be counseled properly, because the mother has always a concern कि इसका आगे क्या होगा, शादी के बाद में क्या होगा, इसको बच्चे होंगे कि नहीं होंगे, ये ऐसा क्यों होगा. So these are the major concerns at that particular age, and mother is very much bothered. So the mother should be counseled properly.
Of course, of course. The family, sometimes I call the father also to see if the girl is obese or mother is obese. So I want to have a look of father also, if he's in the same category, or he can counsel the mother or baby.
I liked one point discussed by Dr. Supriya, that the mother and father both are obese and eating samosas, and we are asking the daughter to reduce the weight. So that principle, this is a take-home message, madam, for me to counsel.
Yes, sir. Sir, this I have also experienced personally. When I started my weight loss, my daughters came up to me and said, "Mummy, if you are eating healthy food, why are you giving us unhealthy food? We will also eat healthy food." When actually they are not obese. So it always makes difference if the parents are doing something healthy. If you are doing unhealthy, they are going to follow you. If you are doing healthy, they are going to follow you. So that is one thing. By passionately, I tell them, my parents.
Point
yeah.
you made.
Yeah.
Thank you.
Thank you, moderators and panelists. Now I request Dr. Monica to announce Navratri competition winners. The competition held by PAC.
Dr. Jyoti, thank you so much. I was actually overwhelmed with the response that Amox has given us for the Foxy Navratri competition. We have received more than 15 individual entries and more than 5 entries from the society. And it was really, really difficult to actually sort out who has given out the best message or who has dressed the best. But in the competition, somebody has to lose and somebody has to win. But every and to actually write down those slogans and email it to us. Can we have this, please? To us? I I would like to declare a consolation prize for Dr. Varsha Lahade Madam in the individual category. She has also sent all the 9 slogans and the 9 dresses. The second prize in the individual category goes to Dr. Varsha Ghate Madam. And the first prize in the individual category is none other than Dr. Supriya Arwani Madam. Heartiest congratulations to you, ma'am.
Thank you so much.
Congratulations,
And
madam.
Thank you. Very sweet of you. Thank you.
We also have society awards. The maximum number of entries that we have received are from 2 different societies. The second being Akluz OBGY Society, and the first one is Apola OBGY Society. Both these societies have actually taken pains to add everything into the one book. Thank you so much. I also would like to extend my thanks to all the panelists and the moderators of this session. It was an excellent panel discussion and very good take-home and crisp messages. Thank you so much for being a part of this.
On behalf of all panelists and moderator, even we would like to thank you, Monica and Jyoti, and a big thank you to Pardesi sir and Amox team for allowing us to be a part of this wonderful panel discussion. Thank you so much. And thank you, Priya and Varsha ma'am, for wonderful moderation.
It's like just after a day we are
Jyoti,
meeting
take
here, Dr. Supriya madam.
Actually. Like Nagina said, it just like it feels like extension of Jabalpur.
Yes.
I can see the Priya shopping, what she's wearing now.
Yes. It's from the Jabalpur.
Oh, wow, wonderful.
Jacket.
Thank you.
So I inaugurated today only.
Great.
Thank you so much. And also Datan madam, thank you. And this is my daughter's birthday today. This is the second birthday.
Oh, so sweet. Happy birthday to her.
Happy birthday.
Happy birthday. Happy birthday.
Thank you. And the first son is gifted by Rachna madam to me.
Oh.
Thank you, Chachi ma'am. Thank you so much. Good
Thank you. Happy birthday to the little one.
Thank you, ma'am. Thank you so much.
You all of you making my work easier. You are making Thanksgiving and what
Okay, then before I go, I should give one shero shairi, no?
Yes. उसके बिना तो माहौल बनेगा ही नहीं, madam.
So we are talking about diet and this and that and exercise. But what the obese people feel from the heart, this shairi is about that. कि diet, calories और exercise सब धोखा है. Diet, calories और exercise सब धोखा है. बरसात का मौसम है, see it's still raining in our part. So बरसात का मौका है, भजिया खा लो, यही सच्चा मौका है. So thank you very much. Thank you.
Thank you. Can we?
Yes, Dr. Jyoti.
Yes, Jyoti, please go ahead.
Yes, Monica ma'am.
Yeah, I would also like to extend our thanks to all the esteemed faculty members, Dr. Manjari Varsakar and Dr. Chaitanya Ganapule, the chairpersons who have extremely been attentive and given excellent comments for the talk, all the participating societies, the delegates, as well as our chief guest, Dr. Pardeshi sir, Dr. May Purandre sir, and Dr. Mandakini madam. Last but not the least, I would like to thank Walter Bushner for his technical support, Mr. Sachin and Yogendra, who have been always at the back end for this webinar. Thank you so much.
Thank you, ma'am. Ma'am, with your prior permission, can we stop this?
Yeah, we can end the meeting now. Thank you.
Yeah.
Thank you.
Can we have a group photo?
Thank you all.
See you soon.
Yeah, group photo.
Yogendra, can you take a photograph, please?
Just ma'am, we'll take.
Sachin is taking now.
थैंक्सगिविंग हो गया क्या?
Yes, ma'am.
नहीं, एक्चुअली ऑडियो प्रॉब्लम था उधर.
Light here.
Thank you, everyone. Thank you for the excellent
Bye-bye.
evening. Thank you so much.
Thank you for
Bye-bye.
the opportunity.
Bye.
See you.
Bye.
Dr. Jyoti, special thank you to you to coordinate the entire session and take pains to gather
Thank
everybody
you.
on this platform. Thank you so much, ma'am.
Giving me opportunity. Thank you so much.
Thank you, ma'am.
Bye. Bye.
Thank you.
Thank you so
Roji,
much, ma'am.
please.
Ma'am, on behalf of Walter Bushnell Head Office, we express our humble thanks to Dr. Jyoti ma'am and Dr. Monica ma'am for giving us this opportunity for this wonderful webinar. So ma'am, I'm ending the meeting for all. Looking forward to another wonderful webinar in the coming times.